that I at least find it appealing, and we'll see what you think. One is that we should give people living with serious illness the option of giving up their entitlement and going into a blended funding situation, something like PACE, but you don't have to be down to Medicaid levels to get into it. And you would know that you would have limitations, be like everything else in life, where the school system does not promise you an unlimited availability of instruction and teaching, but your school system has this sort of track record, and this is what you're getting into. So one question is to allow people to opt out of an entitlement funding stream, but take their money with them, in a sense, and go into a PACE-like capitation arrangement. A second idea is to highly motivate the caregivers and begin to have caregivers not just thinking as we did in the panel here, but thinking as political beasts and making caregiving issues something that is very much on the political agenda. Up to this point, I would characterize what caregivers have demanded as being crumbs from the table. And I think that caregivers should start demanding things like Social Security benefits. When you're providing 40 hours a week of care to your mother, you ought not to be cut out of Social Security. They should be requiring being identified in the record, being trained, having respite as a matter of fact, a number of things, not just, please be nice to us and let us know when mom's coming home. I think that the third thing is that we should allow some communities, we should enable some communities to try to create the Toyota revolution for serious illness care. Try to find the places that have an appropriate mix of leadership on the medical care side, on the social services side, on the behavioral health side, in the civic leadership side, and give them some elbow room to show us, what really good comprehensive care at the lowest possible cost could look like, so that we would have native-born examples. If I show them an example from Sweden, nobody cares. They've got to be somewhere within the boundaries of the states. But right now, nobody can do that because they're hidebound. On the thing that Gwendolyn was talking about, Seema Verma does say that they have the authority. But where is the pressure to get rid of the Part D problem for PACE? Anybody here write a letter about it? Anybody write to their congressman about it? The 40,000 families now being served are not going to generate a letter. Where is the political push to get things changed? So anyway, some responses to those while some people line up to make their comments.
I'm not quite sure about the part. I just had a question about the Part D. Somebody who is not eligible for Part D or doesn't have Part D, if they're low income, ought to be eligible by virtue of...
No, this is about Medicare-only people.
Is enabling Medicare-only people.
The Medicare-only person trying to come into PACE is the only person in the country who does not get any Part D benefits because the PACE statute precludes copays and deductibles, and the Part D turns on copays and deductibles. So the cost per month in the open market is about $50 per month for a Part D, and in PACE is about $1,000 a month.
And that's something the administrator can waive?
Yep. Well,
I doubt it.
Think so.
No, in the way we...
I don't think so.
No, in the way we proposed... Well, very briefly, and I can explain this at greater length, we proposed that the beneficiary pay the PACE program a fee to cover all medications, and the PACE program buy a market-based plan for that person. That appears to be legal, and CMS counsel says that would be legal. So the premium that the patient pays for all medications would technically not be being paying copays and deductibles. It'd be a premium per month. So it's sort of a technical workaround around the statutory issue. But CMS counsel has apparently agreed that, yes, that would work and is within their authority. But, everybody's hidebound. When you sign up in PACE, you sign up in the PACE program's medication plan because almost everybody is poor. And so the PACE programs have never actually dealt with this except in people who are within a month or two of spend down. And they're just sort of spending their last money. So it doesn't matter if they spent $1,200 instead of $50 this month because they were going to be spent down anyway. So this is one that they say they have the authority to do, but they aren't willing to do it yet.
Well,
Go back to entitlement.
As
please.
you know, Joanne, I want to respond to entitlement. I mean, to me, the very notion that someone like you could propose requiring Medicare beneficiaries to voluntarily disentitle themselves to get a benefit that we ought to be providing them anyway shows how low we have fallen as a country in the way we talk about human services and the public responsibility to our federal citizens.
I agree.
I mean, Jesus Christ. I mean, the fact of the matter is that Medicare is based on an expectation of actuarial average costs across a bunch of people. And one way that Gail I know is not supportive of, but one way to solve the Medicare long-term financing problem is just to stop serving all the real expensive ones. But that would also mean that you have turned the program into the opposite of what it was created to be. So, starting on that slippery slope seems to me to be almost inconceivable.
And I've only arrived at this
that
low
we are a
level.
rich enough nation to take the few entitlements we have left and continue to finance them to meet the needs of the people who have contributed to paying into them.
And I would
And
agree
politically,
that
it's just never going to happen. I mean, you know that, Joanne. You can just imagine the kind of headlines the first time somebody who agreed to make that swap had a medical issue. So, I mean, it's like maybe intellectually that sounds intriguing. At any kind of political level, it's like, are you frigging kidding me?
I think
But it
Kathy
still
might
drives
agree.
me mad that I can, with the sweep of my pen, write for a $60,000 drug for somebody who has only a few weeks to live, and it will be filled, and it will be paid for, and I can't get them lunch. There is something truly mad about not having an entitlement to lunch.
Can I jump
I'm
in?
willing to fight for entitlements more broadly, but not to make it possible for me and my ilk to simply continue to gobble up the budgets of every state and
You're
government.
talking about the wrong
But
problem.
you can fix that without disentitling.
Right, exactly.
That problem without disentitling people.
Can you tell how exciting our prep call was for this? We're like, we all want to talk at the same time. Bruce and I haven't told you how we met. We met when I was working on the Class Act, so that also is kind of an advanced beginner, sort of people grown. And if I recharacterized your question, Joanne, or your point, Joanne, is like, why does everybody get everything? Which is the nature of entitlement. I would come at it from a different direction initially, and we would need the data people, the researchers, to do this. I would like to see Medicare experiment with more triggers that were functionally based. So I don't think Medicare can afford a long-term care benefit. I would love when someone first begins to use their post-acute benefits that they got intensive case management and care planning, right then. And that's when you can start to go, yes, that's part of the hole between Medicare and Medicaid that I fell into, because some of the thing you avoid if you invest in a Medicare comprehensive, sort of let's make a plan, it helps people keep from spending down to Medicaid. But it would be good policy. How can we stop looking at all people, and I know there are 8 million people on Medicare who are not 65, but we tend to monolithically think of these programs and buy everything for everyone, which prices them out as very expensive. And could we start to look at functional need as the trigger, not age, which can be a proxy, but it's a messy proxy, but start looking at function, saying if you're on Medicare and you get to this point, like pick something big and scary and something we should all have, which is dental. It's like, well, if all your teeth fall out, there's the trigger. I mean, what do you do so that you can start shaping this differently so that we can start to buy and target to the most the people who in most need of a specific intervention that then doesn't have to cost the whole program all at once. I would approach everything for everyone from that direction rather than having people give up their entitlements. I do agree with Bruce on that.
Let's go ahead and take a question from the audience.
Thank you. My name is Hilary Tsumba. I'm from the Primary Care Coalition and also a member of the Montgomery County Commission on Aging. And I'm surprised that through the course of the day, I have not heard the word ageism or the word ableism stated specifically. At one point, there was a question about where is the political will, and I somewhat suspect that those have something to play in terms of political will. And so my question is, in the experience of the panelists working on these issues, what have you encountered? I'm hoping that you'll tell me I'm wrong and that those issues don't come into play. But if that's not your answer, my follow-on question is, what messages and approaches have you used to sort of move people's perception if that becomes a barrier to thinking more deeply about some of the challenges that people face?
Kathy?
I think the thing that would help us all the most is to have older people advocate for themselves as older people in every venue, in every capital, with all policymakers. I'm 58 years old, so I don't qualify for Older Americans Act yet. I'm often asked to be on panels talking about older people, and I often say, only if an older person talks about being an older person. I don't want an 85-year-old who pretends they're not 85. I mean, let's have older people advocate. And that will start to break through ageism and ableism. I think absolutely you're correct. But it is often an us and them conversation. It's not a first-person conversation. We talk about what do old people need instead of what do we need when we get old. And we have to frame it differently, and we have to have the leadership of older people and encourage them and facilitate their voice. I think it would make a tremendous difference.
Let me just echo Kathy very quickly from sort of another direction, which is, if you look narrowly at public support for Medicare, there's not a considerable age gradient. However, the Kaiser Foundation, whoever poses a question, should we spend more money on Medicare or less? Should we, whatever, the age gradient and continued support for Medicare, in fact, support for further expansion of Medicare, is very, very limited from people in their 20s all the way up through their 80s. What is but Kathy's exactly right. What is, and I always wondered if it was a generational phenomenon of the Depression era folks who were aging into Medicare when Gail and I were there, who were so grateful for the existence of Medicare that they didn't want to complain or ask any questions. But whatever the mythology may be about AARP, whatever, the absence of mobilization of older people, particularly around issues of long-term care, I think is quite remarkable. And I think the younger audience is sympathetic. They just don't hear any noise about it.
See a very different world out there. I think the older population and seniors are an incredibly potent political bloc. They vote more than young people. That, at the end of the day, gets the attention of people on the Hill more than anything else. And I think you actually have seen much more attention being given to what seniors want, not by what the 20-year-olds think seniors should have, but what seniors want, than what we need to be doing for preschoolers, for pregnant women, for people during their early formative years. So I just see a completely different world out there.
Let's take the last question here.
Okay, thank you. My name is John Birch, and I am an angel investor. Angel investors invest in startup companies. And I'm from Kansas City, by the way. A member of something called the Angel Capital Association, which is a national group representing probably somewhere around 150,000 investors. We, as a group, angel investors, are more responsible for innovation in this country than venture capital put together. But that's not why I'm here. I'm here on my own, not representing anybody, but because I'm very interested in healthcare data. In particular, It's my view that electronic medical records are essentially dinosaurs on their way out. And the fundamental problem is that they are provider-centered, they are not patient-centered. Patient data is just as fragmented as patient care is, and as a result, all kinds of mistakes get made. Medical mistakes, as many of you may know, are probably the third cause of death in this country, after cancer, perhaps, and health and heart disease. But as we look, there's no question that things are moving toward patient-centered repositories of information. A lot of data aggregators now, our personal health records and so on, are being developed. But to relate this to the theme here today, you're talking about how to integrate healthcare and social services. And I've heard again and again that there's a problem of not having the longitudinal data on the patient, obviously for care, but also for social services. The beauty of patient-centered data from a healthcare point of view is that it combines data across all kinds of providers. The same integrating organizing principle, i.e. the patient, cuts right across social services as well. I guess I just wanted to throw that out as an idea. I think it is coming. It'll happen slowly in healthcare, but if we could get the pull from social services as well, I think it would make it happen faster, sooner, better.
Thank you. I think Amy has a comment from the Twitter world.
We'll end on Twitter. The last question comes from, Jennifer Brokaw, who is an emergency physician in San Francisco. Sorry, the question just went away. An emergency physician in San Francisco. Father is Tom Brokaw, by the way. Wow. And dear Jennifer, who is a good friend to everyone in this field, wants to know, not that one. So she's interested in the fact that Medicare Advantage plans are able to integrate in-home supportive services. And so she believes that this is predicated on a thought that down the road this would save in the total costs of care. So she wants to know, how is it that they can fund and we can't figure this out elsewhere?
I'm a big proponent. I think we can't get too excited or expect too much of this, but I think the new provisions that allow more flexibility to the Medicare Advantage plans in terms of being able to provide people with targeted benefits to their diseases, that is kind of a lead up to the Chronic Care Act regulation, which should be coming out next year, is moving in the direction of allowing for a more comprehensive treatment. I applaud it. I think it's an important addition. A column I wrote, I saw that Joanne or somebody had distributed. In all fairness, I think we can only expect that to provide so much help. I mean, I think it will improve what we are able to do now, and it may well provide at least enough of a showcase model that if more money is made available for this kind of purpose, this might be a reasonable way to provide it. But it's not like there's a ton of extra money that is likely to be available in the Medicare Advantage. It just is allowing up what seems to be very reasonable additional flexibility to be able to accommodate particular needs of people that have slightly different conditions and therefore medical needs or different levels of frailty within a given condition. So it's moving in a good direction. I don't think we can assume this is a major solution to the problem.
Yeah. I'm going to give the panelists a chance to say a last sentence or two. I would, in regard to this new flexibility that Medicare Advantage plans have, I would just underscore that it is very different to pay for meals or housing because otherwise the person would be expensive than it is to pay for meals or housing because otherwise they would be hungry and out in the cold. Kathy?
So as you know, since you were here, I chose to use my time to publicly confess my envy of the Capable program. The next thing on my list was interoperability and technology. That I don't think meaningful use went far enough, that I think we funded at the expensive place in hospitals and have cascaded out. And to integrate healthcare and social services, at some point we have to have systems where everyone can see the plan of care. People may have different levels of authority and access, but we need a commonly shared plan of care. And whether that's built out from the provider side, which is where meaningful use has gone, or comes from a portable consumer tool, everyone will need to look at the same game plan written in a plan of care in order to really integrate and achieve all that we can in terms of both cost savings and health improvement.
Without arguing with the political realities described by either Kathy or Gail, I think if you put the contemporary political realities against what we know are the demographics and the way the system is working, we're going to be reading newspaper headlines in the next 10 years about old people at home alone dying covered in their own excrement because they fell between cracks somewhere. And it's happening now. We're just not seeing the newspaper stories about it. It's going to happen a lot in the future unless we do something that appears outside the scope of what we're politically capable of.
When I was in the White House in 1992, people representing the Carter Foundation from Atlanta approached us with the notion that they thought there was enough money in Atlanta if they could take all the various programs that were there, plus the amount of money that the business community had committed, and philanthropy in addition that would be that had been promised by the community leadership. They just couldn't get all this money to be in a more useful form, and was there a way that we could provide that kind of jurisdictional authority? We tried every which way that we could think of to come up with strategies, and we loved the concept that people were doing domestic policy under the first Bush administration. And there were a lot of pretty sophisticated thinkers there. And for the life of us, we could not come up with a strategy that would allow us to allow them to be able to do this perfectly reasonable strategy. Somehow we need to be able to figure out a way, as frustrating and as grim as some of the stories that you have heard, particularly from Bruce and Joanne. I think it's even more frustrating and more nonsensical to say 20 years ago, and I suspect we could duplicate those efforts now, the leadership of a large community, this is not just a little small town somewhere in Atlanta, says it's willing to take on the responsibility for this, making up any deficits with pledges of commitment from their own community leadership and just using the money smarter. And we can't seem to figure out a way to make that happen. Now, to me, that is really unacceptable. Maybe someday we'll be able to fix it. We are now 25 years later. I can't believe that we haven't gotten any closer, but we haven't.
Thank you, Gail. With that, I want to make sure that you understand that when we started planning this day, we said we wanted to give you a provocative day, and I think that certainly Joanne in our last panel has helped us with that. And then also, before we give them an applause, for the true policy wonks around us, including Gail and Bruce and Kathy, if you take a look at the Dying in America report, which is what this day is built on, buried in recommendation number 4 are the words from the National Academy: to the extent that the additional legislation is necessary to implement this recommendation, the administration should seek and Congress should enact such legislation that would allow you not to fill in the budget hole. So thank you to Joanne and the panel.